Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to have with me today Professor Mike Kirby. Hello, Mike.
Hello, everybody.
Mike is editor of Trends in Urology and Men's Health and was previously visiting professor to the University of Hertfordshire, the Centre for Research in Primary and Community Care, and the Prostate Centre, London. I've known Mike for many years now, and he's a regular speaker at our live events. For example, he's coming to speak at MIMS Learning Live North in Liverpool on 4th of December 2024 on the topic of men's sexual health and lower urinary tract symptoms. Today we're going to be talking about diagnosis of prostate cancer in primary care and management of men who've had prostate cancer treatment, because we feel it's a very important issue, and timely because this episode comes out in the Men's Health Awareness Month of Movember. So Mike, I've sent you some questions through, but the first one was really quite a general one about GPs and when should they have prostate cancer on their radar, and what kind of symptoms and signs and family history should they be thinking about?
Well, it should always be on their radar. Perhaps I'll just fill you in how I got interested in this disease area, because it's rather relevant. When I was a GP, I had a young man aged 42 come in with back pain, and he turned out to have metastatic prostate cancer and was dead in 6 months. Now, this was in the early 90s, and the PSA test had just become available as a new test. And I got thinking, gosh, there must be a better way to diagnose men than just wait for them to come in with metastatic disease. So we did a research project. We did a pilot screening study using PSA, this new test, and a digital rectal examination on over 600 men in my practice. So we got rather good at doing rectal examinations as a result of doing this. But we found 12 tumours in the process of doing that, which was about 2% of the screened population. And we wrote it up saying, yes, you can use this test to diagnose prostate cancer, but you get quite a lot of false positives. So in the sort of slightly raised PSA range, about 1 in 4 raised PSAs will be due to prostate cancer. The other 3 will be due to benign disease. And at that time, anybody who had a raised PSA ended up having multiple biopsies through the rectum. So in fact, we did some harm, because 3 men ended up with septicemia. So we advised, yes, it's a reasonable test, but it's not really a test good enough for screening now. And, prostate cancer, we're going to diagnose 55,000 men this year. 10,000 men will die of it. And the worrying thing is that about 20% are already metastatic when they get diagnosed, and that goes up to 50% in Scotland. And another 20% have locally advanced disease, which is quite difficult to cure sometimes and involves a lot more treatment. And of course, if we're allowing these men to present with advanced disease, then it's very expensive for the NHS, because we catch them early, we can cure them. If we catch them late, they have very expensive treatments such as chemotherapy, radiotherapy, abiraterone, enzalutamide, etc., etc. So let's try and diagnose these men early before they present with advanced disease. So GPs need to be alert to the possibility that men over 50, and if there's a family history, men over 40 turning up who might have prostate cancer.
Okay, and if a patient raises prostate cancer as a worry, or you suspect it during a consultation, or perhaps take a step back, when would you suspect it during a consultation? What are the kind of things that you're looking out for?
Yes, well, lower urinary tract symptoms are the obvious one, such as urinary frequency or hesitancy or urgency. Erectile dysfunction may sometimes be a presenting feature, or bleeding into the urine, visible hematuria. But that being said, 75% of prostate cancers occur in the outside of the gland. which means they're nowhere near the urethra. And therefore, they may not cause any urinary symptoms, and they may be very silent and then break through the prostate capsule before anybody really knows the disease is there. So I don't think we can rely on symptoms. The metastatic symptoms are often bone pain, such as back pain, and we don't want to see men with that. So I think we do need to be suspicious in men with those symptoms, but we need to be alert anyway, all men over 50. And remember that men who have a family history and their father or their brother have a 2.5 times more greater risk of developing prostate cancer. And black men are much greater risk. They're twice as much at risk as white men. So 1 in 8 white men will develop prostate cancer at some time in their lifetime. And, frighteningly, 1 in 4 black men will develop prostate cancer. And that is why, at the moment, we're really recommending a sort of risk strategy. So let's do a PSA test on all men with a family history of prostate cancer or a family history of ovarian or breast cancer because of the link with the BRCA1 and BRCA2 gene. And actually, also, if there's a family history of pancreatic cancer or colon cancer, the risk of prostate cancer is actually raised. And prostate cancer research, I've been working with them, and we've put together a petition which 138,000 people have signed, recommending a risk strategy screening to try and detect the men with a family history, and also for black men.
Right. And saying that you should have on your radar that black men, for example, take them as an example, they're much more at risk. So what's your impression of how widely that is known in general practice, and how widely action is taken on the basis of that fact?
Well, disappointingly, Pat, I don't think it is widely known, the extent of it. The Prostate Cancer Risk Management Programme says that any man over the age of 50 is entitled to a PSA test on the NHS free. And I don't think that is widely known by the general public. And it's not always accepted by GPs. In fact, often men do get put off. Well, it's not a very reliable test. I shouldn't have it if I were you. I must say my view is rather different to that, because if a man knows his PSA, he need not die of prostate cancer. If he doesn't know it, he might. And I think the PSA result is another example of know your numbers.
Right.
If you know your blood pressure, know your cholesterol, know your blood glucose. If you know your PSA, can tell you your likelihood of developing prostate cancer in the future. So, for example, there's good research data that shows if you have a PSA test in your 40s and it's less than 0.5, you're highly unlikely ever to get prostate cancer. If you have a PSA test in your 40s or early 50s and it's over 2, then you're 16 times more likely to develop prostate cancer. So in those men, the GP then has a baseline, and they can have an annual PSA test, and if it goes up by 20% in any 1 year, they should be referred for an MRI.
And the strategy that you're proposing is that you take cohorts of men who you would identify as having a higher risk profile anyway, and then doing PSA testing on them. Is that right?
Yes. Yeah. And we're going to go to Parliament in a couple of weeks' time following that petition to discuss it with the MPs to see if we can get some leverage to try and detect prostate cancer early in those men at the highest risk.
Yeah. I'm not sure if this is within the research that you've done or that you know of, but are there factors that prevent black men from coming forward to ask about PSA testing?
Yes, there's quite a lot of research in that area. In fact, we're working on that at the moment. There's a lot of distrust of the health service. There's a lot of misinformation about the consequences of prostate cancer treatment in terms of particularly sexual side effects. And I think it puts black men off coming forward.
Yeah. And do you know of anyone who's trying to do some work in that area to change beliefs?
It's also, if you live in a deprived area of the UK, you're much more likely to present with advanced disease. And that's particularly true in the northern parts of the UK compared to London. So I've quoted a figure of about 23% advanced disease in London. It's double that up north.
Right.
So, and I think that is partly related to areas of deprivation. It may be, of course, that there are more black men living in deprived circumstances than white. And there are research ideas that if we send around a man van to these areas, we can attract people to get into the van and have a PSA test. The thing is, the treatment pathways changed so much, Pat, since that first study that I did way back in the early 90s, because now we have MRI. So if you have a raised PSA, it doesn't mean you automatically go to biopsy.
Right, yeah.
And in addition to that, the biopsies are now done through the perineum, not through the rectum. So the chance of causing infection with the biopsy is now much, much, much less. And with MRI, we can avoid almost a third of men actually needing a biopsy, because if the MRI is normal, then you don't need any further investigation. So the treatment pathways change. I think now there's much less worry about doing harm than there was in those very early days when we were causing problems.
Yeah.
And the other, I think, good news is that we are doing active surveillance. So if you have a low-grade cancer, you don't necessarily have to have treatment. It can just be followed up with MRI and PSA tests over many years. And in fact, the national prostate cancer audits demonstrated that only about 4% of men are being overtreated these days. So, there's a lot of good news around prostate cancer, but we still have this problem of men presenting late.
Yes, so that's something that needs to be addressed, given that other factors have changed for the better, by the sounds of it.
Yes.
That's still a piece of work to be done. But yeah, it sounds definitely promising that things have moved on. So say I'm a GP and I've got somebody in front of me who is concerned about the possibility of prostate cancer. What are my next steps in terms of testing and examination?
Well, the Prostate Cancer Risk Management Program has a very good handout that can easily be downloaded, which gives the pros and cons of having a PSA test. So it's important that you counsel men that if you have a PSA test and it's raised, you are going to get into the 2-week wait situation, and then you'll have an MRI, you might have a biopsy, and then you might end up either having a radical prostatectomy or radiotherapy as the two favoured options. So there's an important counselling role before you take blood for a PSA. I don't think it should just be added to a list of tests without telling the patient you're doing it.
Yeah.
It is necessary to have that discussion and a shared decision about doing the test. In addition, do you not need to do a DRE? And that's one thing I didn't mention when I talk about men not wanting to come forward for the PSA test, is that they are significantly worried about this digital rectal examination, particularly for black men. And in fact, the latest research does suggest that actually doing a digital rectal examination doesn't add much to the PSA in terms of making a prostate cancer diagnosis. And that's because with your finger, you can only feel the back of the gland. You can't feel the front of the gland. So you miss quite large areas of the prostate by doing a digital rectal examination. My view is that I think it's quite a good idea to examine the prostate clinically, because it is a clinical skill that GPs don't want to lose. And unless you're doing a lot, I think it's quite a difficult examination to get familiar with. And it does tell you whether the patient has a very large benign gland, which might be putting the PSA up. In which case you can tell the patient, look, you've got a huge prostate. I think your PSA is highly likely to be raised due to that. So don't worry, but we are going to do an MRI. So I'm sending you off to urology. So the prostate should normally feel quite small. size of a walnut. If it's the size of a ping pong ball, then it's about 30 grams. So they normally should be 20 grams. If it's a golf ball, it's over 40 grams. If it's a mandarin, it's 65 grams. If it's a tennis ball, it's 135 grams. And I have found a few tennis balls over my career.
Okay.
But benign enlargement does cause urinary symptoms very often because it does compress the urethra. So men with benign disease do have lower urinary tract symptoms.
And if the GP is thinking of doing the PSA test, there's a bit of counselling to be done around that. And then when you get the results back of the PSA test, what's the kind of threshold for referral and referral pathway that you would think about if the test is abnormal?
Well, that's where there is a bit of controversy at the moment, because the Prostate Cancer Risk Management Programme says any man with a PSA over 3 needs to be referred to urology. NICE has age-specific levels, so 40 to 49, if it's more than 2.5, they should go. 50 to 59, it's more than 3.5. 60 to 69, it's more than 4.5.
Okay.
And 70 to 79, it's more than 6.5. So normally the local commissioning group has either accepted the 0.3 for everybody, or they may have picked the NICE guideline. So it will depend on your locality. I think the NICE guideline is designed to avoid older men getting referred unnecessarily. Although my personal view is that I think 0.3 is easy, and we do find obviously the older men are more likely to harbour prostate cancer than the younger men, after all.
Yep. Okay. And will GPs kind of be aware of what the next steps are going to be for the patient once they've been referred? Or do the GPs have a kind of information need about how to prepare the patient?
Yeah, I think for any cancer, we have the 2-week wait criteria, but of course that rarely gets met with the current waiting times, and it's a problem. There is a 28-day faster diagnosis standard. It's 75% of men should be seen within 28 days. There's a 62-day referral to treatment standard, and that's meant to happen in 85% of cases. And then there's the 31-day decision to treat standard, which they want 96% of people to have a decision about treatment made within that month. So the 2-week wait's quite a sensible thing, really. It often tends to overrun, but when the urologist sees the patient, or they may not even see them, they may just send them straight for an MRI and then see them with the result of the MRI together with a repeat PSA test. And I think that's an important thing too, really. If the PSA is slightly raised, it's quite a good idea to repeat it.
Yeah.
Because if it's done under ideal circumstances, then you can rely on it, but it may not be. For example, they may have had intercourse the night before, or they may have arrived on a bike.
Okay.
And come quite a long way. They may have done very significant exercise. All of those things can put the PSA up a bit. So my view is, your PSA is up a little bit. I think we should just repeat it. Make sure you don't have sex the night before or even 48 hours before. Don't arrive on a bike and don't do violent exercise. And then we'll see what the second result is.
And do you think GPs routinely do that, or is that not something that would generally happen?
Some do.
Some do. Yeah. Okay.
In primary care, it's very hard to say generally for anything these days because there is huge heterogeneity across the country. And if you ask practices whether they have an interest in men's health, you get a very disappointing response. So I think GPs, to some extent, have got a little bit de-skilled in men's health.
Interesting. The time is right for more awareness about how to.
I think everybody should be listening to this podcast.
Great. Good to have your recommendation. So once somebody's kind of in the system and seen a specialist and they're thinking about treatment options, those include presumably radiotherapy, chemotherapy. There's a range of options. And is there anything that GPs perhaps need to know about what has changed with those?
Well, they've all got better and less traumatic for the patient. So if the man's got curable disease, he'll be offered a choice, and that's decided and recommended by a multidisciplinary team. Often for the older man who has lots of comorbidities, it's probably safer to use radiotherapy. For the younger man with no comorbidities, then removing the prostate using robotic surgery and avoiding damage to the erectile nerves can be a very effective and straightforward treatment. And in fact, in the old days, incontinence used to be a bit of an issue, but well over 90% of men at a year are fully continent after radical robotic prostatectomy. Erectile dysfunction is just as bad actually in the radiotherapy as in the surgery.
Yeah.
But in radiotherapy, it comes on a little bit later than it does with surgery when it's immediate. So I think it's very important for all men having treatment for prostate cancer, whether it's radiotherapy or surgery, they get put on a PD5 inhibitor prior to treatment and continued right through the course of treatment. One of the considerations about having radiotherapy is that it's always combined with androgen deprivation therapy.
Yeah.
So of course that makes the erectile function worse, and they may be on it for up to 18 months or sometimes 3 years. And those men feel pretty awful when they're living without any testosterone at all, because the theory is that the radiotherapy works better in men who are androgen deficient.
Right.
So that's another consideration. The other consideration is that if you have surgery and there's a local recurrence, then you've always got radiotherapy up your sleeve.
Yeah.
Whereas if you have radiotherapy, then actually surgery would be really difficult after radiotherapy because of all the fibrosis that comes with the radiotherapy. So that's not really a practical option. So with surgery as the first option, you've got belt and braces. You've always got radiotherapy up your sleeve, and you avoid the months of androgen deprivation therapy.
Yeah.
For the patients with metastatic disease, then they all get androgen deprivation therapy, which is where the GPs come in, because if you take away testosterone, you increase the risk of cardiovascular disease and diabetes. And of course, we're experts at managing those risks in primary care, whereas urologists and oncologists and radiotherapists are not. So it's very much down to primary care to look after the men on androgen deprivation therapy, to provide them with PD5 inhibitors to try and help them with their erectile problems that come with the low testosterone.
Yeah.
And Pat, it's fascinating that PD5 inhibitors were first researched for cardiovascular disease. And because the men got erectile function back, they refused to give the pills back at the end of the study. So all the pharmaceutical companies just researched and marketed PD5 inhibitors for erectile problems. Whereas we did a study looking at GP databases in men attending diabetes clinics in Cheshire, and we compared the men with diabetes who were taking PD5 inhibitors and those who were not. And surprise, surprise, and we were surprised, because you'd expect the men with erectile problems to be more likely to have heart disease, because they're declaring themselves as having vascular disease, because we know erectile problems come about 5 years before a heart attack. Anyway, these men had a 38% less chance of having a heart attack or a stroke than the men who weren't taking a PD5 inhibitor. And funny enough, the following year, there was a Swedish research group who did the same study on cardiac patients, finding out those who were taking a PD5 inhibitor, those who weren't, and the men taking a PD5 inhibitor had almost the same reduction, more than a third less heart attacks and strokes than the men who weren't taking them. So the bottom line is that PD5 inhibitors are cardioprotective. And if you're treating a man with androgen deprivation therapy, but you're increasing his risk of a heart attack or a stroke by taking away testosterone. So it's very important to give a PD5 inhibitor daily. And tadalafil is only a few pence a day now. It's generic, it's off patent, so it's ever so cheap. So 5 milligrams of tadalafil, a statin, make sure you've got the blood pressure controlled, make sure they're not got pre-diabetes. If they've got diabetes, then using a GLP-1 agonist is probably a good choice because that is cardioprotective, along with the SGLT2 inhibitors, which are also cardioprotective. So those are the drugs of choice if the man also has diabetes and is on androgen deprivation therapy. It sounds complicated, but it's pretty straightforward.
Yeah, and I'm sure for GPs that's all within what they're routinely doing in clinical practice anyway. But it's just
that's
focusing on
bread and butter of looking after your diabetes patients well.
Yeah, absolutely. But it's just remembering to have that as a flag, I guess, when you know that somebody's had prostate cancer treatment. And are there any other sort of complications or adverse consequences that GPs should be aware of that they might encounter in patients who've had prostate cancer treatment?
Well, radiotherapy can often cause a low-grade proctitis and sometimes a low-grade cystitis because of the close proximity to the bladder and the rectum to the area being treated. So you need to be alert for men presenting with those symptoms if they've had radiotherapy, and be prepared to send them off to have the rectum examined to see if they've got any ulcers or any bleeding, and for the bladder, a bladder scan to make sure they haven't got bladder cancer.
Yeah.
For the men who have had surgery, it's really sometimes there's continence issues. That can be helped with pelvic floor training exercises, and for both erectile problems managed with a PD5 inhibitor and use of a vacuum device, because all these men get penile shortening as a result of both surgery and the radiotherapy. And if you use a vacuum device regularly in the first 6 months, it reduces that loss of length of the penis, which seems to upset the men considerably.
Right.
And it also helps the erections come back. So we recommend an erection restoration program for men with prostate cancer, which includes daily PD5 inhibitors, 3 times a week or daily if they can, use of a vacuum device. And we teach the men to self-inject with Cavaject or Invicorp to produce a chemical erection once a week to try and keep the structure of the penis healthy. Because when men get treated for prostate cancer, they lose their nighttime erections. Now, those are important. Most men should get 40 or 50 minutes of nighttime erection every night, not because they're dreaming about their beautiful partners, disappointingly. It's a physiological thing that provides oxygen to the tissues of the penis at night. So if you lose those nighttime erections, then you do lose structure in the penis, you lose smooth muscle and increase the connective tissue. So the idea of regular erections, either by a PD5 inhibitor or a vacuum device or by injection, is to keep the penis healthy while we're waiting for the nerves to recover.
Okay, well that's really practical advice, and I'm sure hugely beneficial for the patients. I was going to ask you about future developments, but before that, I just wanted to go back to one thing you mentioned, which was that these days there's more what you called active surveillance. Could you talk about a bit more about that? Because it sounds like something that might possibly be a bit alarming for the patients themselves and cause some anxiety, but I can see the rationale for it. So could you tell us a bit more about that?
Well, I've always told the patients that you might have a pussycat or a tiger.
Right.
You don't know until you get the biopsy result, and the MRI result. So the MRI can give an indication of malignancy, and the biopsy examination will also give information about the degree of malignancy. And of course, we do know that many men can live with prostate cancer. It never does them any harm. And what we don't want to be doing is taking prostates out or giving men radiotherapy if they've got a prostate which has a not very aggressive prostate cancer within it. So there's quite a reasonable cohort of men who have low-grade prostate cancers who will be offered active surveillance. And I think you've alluded to the fact that this can be a bit scary.
Yeah.
Gosh, I've got prostate cancer in my prostate. They're just watching it. Or I think I'd rather get it treated, please. So that's a discussion that has to be taken. A lot of men do start on active surveillance and say, "Oh, this is too stressful. All these PSAs and MRIs. I'm always waiting for some result."
Yeah.
It's like the sword of Damocles hanging over me. I'd rather just get home and get it treated. So there is quite a high dropout from active surveillance. But for some men, it works really well. And of course, if you have active surveillance, you miss all that erectile dysfunction,
Yep.
incontinence, bladder problems, rectal problems, androgen deprivation therapy. You don't have any of that. So your quality of life actually is much, much better than the men who get treated.
Yeah.
So that's the sort of discussion I have with these men. And I say, well, it's up to you. I can't tell you what to do, but all I can tell you is you've got a cancer that actually isn't really very aggressive. And it would be pretty safe to just monitor it for a while. And if it shows any sign of changing, if your PSA creeps up or the MRI changes, then, we'll offer you treatment. But it is pretty safe to wait and see. But I agree, it's not something that I would wish to go through myself.
But presumably, as you say, there is a cohort of people who can just take that on board and think, yes, for me, the benefits outweigh the risks
There's a very large
at the moment.
cohort of men
Yeah.
on active surveillance.
Yeah. Okay. Oh, really, really interesting. And in terms of the future, what are you already talked about some things getting better in this arena.
Yes.
What other future developments do you hope to see in this field?
Well, I've seen huge progress, really. MRI made a huge difference. That young man who presented to me in the early 90s was dead in 6 months. Now, he'd probably live perhaps 6 or 10 years. So, wow, we've made big progress. And that's partly due to the fact we are diagnosing people a little bit earlier, but it's like my school report, could do better. And I think we've got newer drugs now. We've got enzalutamide and abiraterone, which target the androgen receptor. So we get much less prostate cancer advancing now because it's constantly being blocked because the androgen receptor is being blocked by these newer drugs.
Mm-hmm.
We've got targeted radiotherapy now, which we can also use, and chemotherapy. Chemotherapy never used to be used in prostate cancer, but now there is quite good evidence that using chemotherapy can make a big difference. So there are more options, and of course there's a lot of research in this area. There are new androgen receptor blockers coming online all the time. The problem is they're very expensive, these new drugs, which is why I alluded to the fact that if we can diagnose them in early, it's going to save the NHS a lot of money. We're getting much better at treating it. We're much better at diagnosing it. We're much better at stratifying patients into low risk, medium risk, and high risk, so we can counsel them about their treatment. And we've got good options for managing the side effects of treatment. I've seen tremendous progress in the area, but there's still a long way to go.
Yeah.
There's still a lot of men out there don't know they've got prostate cancer. And we need to find them if we can.
Yeah, absolutely. So still work to do.
Yes.
Well, thank you so much for talking with me today about prostate cancer diagnosis and management. Really fascinating. So we'll hope to revisit this topic on MIMS Learning have you speak about it again at future events? Because I know you've done so in the past, and it's great to raise awareness of this area.
Yeah, well, I'm always happy to talk about it because it's a subject very close to my heart, and it is the most common cancer in men now, so it's something that we should be taking very seriously.
Absolutely, deserving of attention. So thank you very much for joining us today. We'll just say a huge thank you to Professor Mike Kirby for talking to us today and sparing the time.
It's a pleasure.
And don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thanks for listening. We've been the MIMS Learning editorial team. This episode was produced by Till Owen. Don't miss next week's discussion episode. We'll see you then.